Welcome to the webinar today on promoting the rights and health of transgender people as a public health equity priority. I have a few housekeeping things that I want to let you know about before we get started. We do have English closed captioning that you can access by clicking on the CC button at the bottom of the screen. So I think it's in that little, there's an icon that has 3 dots on it that says more. I think that's where you're able to access it. And we have disabled the chat box out of an abundance of caution and recognizing the importance of safety for our panelists. We have disabled the chat box for participants, but we do have a Q&A box that will be open throughout the webinar. And we're really encouraging you to put your questions in there. We will compile them, and then we'll pose the questions to the panel towards the end of the event. Please submit your questions early in the event, and as they come to you, this will help our behind-the-scenes folks get things organized, get this ready for the discussion period. And if we don't get to all the questions today, we'll do our best to send some resources and some responses in the follow-up email. And as well, our conversation today is being recorded, and after the webinar is done, probably sometime next week, we will share the recording with everybody who registered by email. We can also share the slides, and we'll compile any resources that are that we share in the chat box and any others that happen to come up. And you'll notice at the bottom that there's a reaction icon. So this allows you to react with positive and affirming types of reactions to what the panelists have to offer. You will see that there is a raise hand option, but unfortunately we will not be unmuting lines for participants, again, out of an abundance of caution and in respect of safety. So please just know that if we're not answering the raised hand, we're not intentionally ignoring you, but we need to maintain the safety of the platform as priority. And at the end of the webinar, we will add a link to an evaluation to the chat box, and it will also pop up in your screen. And we take these evaluations really seriously. They help us report to our funder about impact, but they also help us to plan future events and conversations about this topic. And this has been a huge topic of interest to our audience. So I please ask you to take about 2 minutes to do the evaluation after the webinar is over. And before I go any further, I'll acknowledge that I am speaking to you from Mi'kma'ki, colonially known as Nova Scotia. I'm sitting on the campus of St. Francis Xavier University, which is the host organization or host agency for the National Collaborating Centre for Determinants of Health. And I always reflect on what it was like to grow up here in Mi'kma'ki in Nova Scotia and have no knowledge about the number of Mi'kmaq communities, as well as the deep and rich history of African Nova Scotian peoples. Nova Scotia is the first place that people of African descent hit on their way to arriving to Canada. And so we're really proud of that history. And I want to recognize that I am here on those lands as well. And because we're a national organization, I would extend this gratitude and this acknowledgement to our First Nations, Inuit, Métis communities across the country, as well as our communities of African descent, with thanks for everything that I've learned and continue to learn. And for folks who don't know about us, we are one of 6 national collaborating centers across the country. I will not spend valuable time talking about this. I would encourage you to visit the website that you can see here on your screen. We are the only one located in Atlantic Canada. We each have a different focus when it comes to public health practice, and we collaborate and work really well together. And I'd be happy to talk to you anytime about our centers. And before I turn, I guess, things over to our speakers, I do want to tell you a little bit about myself. So, as I said, I'm Diane Weichel. My pronouns are she and her. I've been with the National Collaborating Centre for Determinants of Health for just over 10 years. I'm also a white, cisgendered, heterosexual woman. And, while there's a number of structural and social determinants and inequities that have impacted my own life, when it comes to this conversation, I'm who the world works for. So I walk around with privilege that's associated with being straight and cisgendered every single day. And I get that. And I don't pretend to know what it's like to be a person who is transgender or who's gender expansive. I don't pretend to know what folks need to be healthy. The experts on that are the people who are within the 2S LGBTQI plus community to tell us. And there's so many people from that community in my personal life who I love a lot. I love very, very much. So that's where I come from. And it's why I come to this work. I come to it from a place of love. And hopefully, by telling you this bit about myself, I can model some of what everybody can do to promote health equity for transgender and gender expansive people. We all have a role to play here. It isn't up to the 2SL LGBTQI plus community to do this work. It's up to all of us to do this work. And those of us who are not part of the community, we need to support and play an active role in this work. And we need to be visible, and we need to be brave, and we need to be willing to step out and be willing to make mistakes, because it's the right thing to do. And it is the right way to be. So I'm privileged. Now that you know that bit about me, I'm very privileged and honored to be joined by this panel of folks who really is the dream team. And I have learned so much from them over the many, many months that it's taken to plan this event. And I would like to now turn the mic and ask each of them to introduce themselves. So Veronica, could we maybe get started with you?
Hello, everybody. My name's Veronica Merrifield. My pronouns are she, her. I live in Unamagi, colonially known as Cape Breton, part of Nova Scotia. But as you can tell by my accent, I'm not from Nova Scotia. I am the founder of the Cape Breton Transgender Network, advocacy and peer support organisation that has in more recent years has become Nova Scotia-wide and Canada-wide and even international, because of some of the work that I do. I transitioned nearly 3 decades ago, just over 3 decades ago, and I've been doing this advocacy work for a long time, although not as full-time as it is now. And I'm pleased to be here. Thank you.
Thank you very much. Brittany, would you like to go next?
Sure. Hi, everyone. My name is Brittany Jakubiak, and I use they, them pronouns. For a visual description, I'm a white person with short dark hair and glasses, and I'm wearing a white button-down shirt with flowers. I live and work in Prince Edward Island, also known as Abequit, which is located in Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. I am the Director of Research at EGAL Canada, and much of my research over the last decade has focused on social justice issues and has centered folks most marginalized and underserved. I'm a qualitative researcher specifically, and my work at EGAL focuses primarily on 2S LGBTQI health, GBV, and employment, but many other topics as well come up in our work. And I've been in this role for just over 3 years. And recently, our team released a report on healthcare access and priorities of lesbian, bi, queer, women, trans, non-binary people in Canada. And if folks are interested in today's topic of the webinar, I would encourage folks to check out this report. Thank you, and I'm really happy to be here.
Thank you, Brittany. Travis, can you say a quick hi?
Yeah, hello. Thank you so much, Diane, for gathering us together. And I want to express a huge amount of gratitude to Brittany and Veronica for sharing this space with me, and really looking forward to the discussion. My name is Travis Salway. I am a queer cis man. I use he, him pronouns. I'm descended from European settlers, and I take that history very seriously. Thank you, Diane, for taking the time to offer some thoughtful reflections on our roles as settlers. I just want to add one point to that, which is what I have been learning over the last 5 to 10 years from the Two-Spirit movement and Two-Spirit leaders. I want to express, give credit to, and express a lot of appreciation to the work that Two-Spirit people are doing to remind us that trans people have always existed, Two-Spirit people have always existed, and gender diversity is in fact a very natural and beautiful thing. I've just finished reading the memoirs of Miss Chief Eagle Testicle Volume 1. I'm an academic, so you're going to get a few book plugs from me here. So for those of you who know Kent Monkman, he's a Two-Spirit Cree artist who does really just inspiring, brilliant work. Mischief Eagle Testicle is his alter ego, who's gender fluid. And this book is a beautifully illustrated history of Turtle Island before European contact. And it really just reminds me, Kent Monkman's work and other Two-Spirit leaders' work reminds me that we have a lot to learn in terms of dismantling European Christian colonial ideas of the gender binary. And that's really the context in which this conversation occurs. And I didn't mention anything about who I am professionally. I'm a social worker by training, but I'm also an epidemiologist. I've worked in public health with the BC Centre for Disease Control for the last 16 years, and I'm now an assistant professor in the Faculty of Health Sciences at Simon Fraser University. So looking forward to this conversation. Thank you for having us.
I'm so glad we're finally here. I also want to thank my colleagues who are in the background supporting us with technology, questions answer, safety and security, and that's Carolyn Bosson, who is our knowledge translation coordinator, and Mandy Walker, who is also a knowledge translation specialist, both with NCCDH. You won't see their faces today, but they are there, and they are just as much part of delivering to this event today as us. So I cannot thank you all enough for the collaboration over the many months. We have over 850 registrations, and right now we have 405 people online. There is obviously a tremendous amount of interest and support and passion for public health to take an active role in this space. So now that we've met everyone and we're ready to dive in, I can get my, these are our objectives for today, which most of you know from having registered for the webinar. And I want you to keep these in mind for when you get the evaluation. But I mostly really want to jump right into the conversation. So we have a few guiding questions that I'm going to pose to the panel. Hannah's going to respond, and then we're going to have some conversation. And I thought we would really jump in with why this is a public health issue. Why is it important to talk about health equity, specifically for transgender and gender-expansive people? Veronica, I know you have some thoughts on this, and we'd love to hear from you. So maybe we could get started with you.
Yes, absolutely, and more thoughts than we've got time for, I'm sure. I want to thank Travis for mentioning in his introduction that transgender and gender and Two-Spirit people have been around for a long time. And this is one of the areas that I do speak to. There's an amount of language and archaeological evidence that goes back thousands of years in multiple cultures. But some of the longest or oldest pieces of those language and cultures are those pieces around the Two-Spirit community in Canada, and the number of descriptions that are around for the various pieces that we would now call to us LGBTQ+. But the very fact that some of the ancient languages in the European Middle East have words and descriptions that go back thousands of years mean that transgender, intersex, gender non-conforming, these kind of people existed enough for that language to be developed. So the enforcement of the binary is what has become the newer thing in the last sort of 1,000 years or so, and now we're seeing the effects of that. So why is it important to talk about health equity? I mean, very bluntly, it's about suicide prevention. And my own story has suicide attempts in it when I was a teenager. And that's because the information wasn't there. That's because I didn't know. It's because I thought I was the only one. As a 4-year-old, I didn't have the language. I didn't know who to reach out to. I didn't know what to do about it. And as an 8-year-old, when I asked for help, it was denied. I'd like to think it was just because of lack of education, but I know that there was a religious element in there too, which I now see years later was part of conversionary practices. But I didn't realize it until my work to help get a conversion therapy ban. There are an awful lot of barriers for those seeking help, for those that are trans or gender expansive. There's issues in, as you can imagine, growing up. If you don't have that education, if you don't have a safe space, you don't know what to do with it, and you think there's something terribly wrong with you. This is why schools can be the safe space for children and students who need that safe space that they know they don't have at home. It's the place where education can happen on a broader ground that allows those children to at least understand that there is something other than the gender binary. Safe space creation is a big piece, but as they move through that in terms of health, there's a very prescribed path through most health authorities, and certainly in Canada we have multiple pieces of that, with provinces doing healthcare in different ways, but essentially the medical mode is the same. Almost all of my initial contacts by folks is asking the question, what do I do? How do I engage with the medical system? How can you help me? And I help them navigate it. And peer navigation, I think, is another really important piece of providing health equity for all sorts of people, but certainly in this way. And particularly when a lot of those who work in the health system, that would be those frontline practitioners, don't necessarily understand the system themselves. They don't understand what they can do, and very often punt it off to somebody else because they don't want to do it. In a larger urban area, that's usually not too much of a barrier, although it still is a barrier, but in a rural location that can be a big barrier. And certainly here in Cape Breton, that barrier can mean that they've got to do a 5-hour trip to Halifax and a 5-hour trip back because the local medical practitioners don't want to do that. It becomes a huge barrier. So when I spoke recently to the Dalhousie medical professional development, and I had a single slide with the medical model on it and the points where there are barriers, and there are at least 7 that I identified that are the trouble points that people come to me asking for help. These are the reasons that it's important to talk about health equity. The services are often denied, the services are difficult to access, and that's even if you know what you're doing. But prior to that, if you think you're on your own and you haven't had that education, you're going to be in a very difficult place. So education is so important for everyone, for those who are in schools, for adults, for those who work in a service. And it's almost always about what can we do to help folk get what they need without them feeling that there is no hope for them, without them sliding into the despond that leads to suicide. Suicide rates are high. Those in the transgender community report having tried suicide at a much higher rate than in other areas. And I am pretty convinced that a lot of people who do end up taking their lives and haven't told anybody about it probably lie on the 2S LGBT spectrum somewhere, and they just feel that they haven't got hope. So that's why it's important for me.
Yeah, that's beautiful, Veronica. And we've spoken a number of times, and every time I talk to you, I learn something new. And when I think about what you just said, when public health is part of that greater health system, public health provides services, mental health and suicide are public health issues. Equity is a public health issue. Human rights, social justice are public health issues, right? So that's, and there are critical pieces affecting the transgender and gender expansive community that fall under that umbrella. Brittany, I'd like to go to you. I'd like to hear your thoughts on why it's important to talk about health equity for the transgender community.
Sure. Thanks so much, Veronica, for all of that. So Veronica mentioned that, gender affirming care is suicide prevention. And that's so true. Equitable and barrier-free access to gender affirming care can truly be life-saving and life-enhancing. And that's one of the reasons why it's so important to talk about trans health equity right now, because there's a lot at stake in our country, including trans rights and access to care, but also women's rights, as well as sexual and reproductive rights. In some of our provinces, we're seeing unprecedented policy and legislation rollbacks. We look at what's happening in New Brunswick, Saskatchewan, and Alberta. We also know, like many on this call, that these efforts aren't necessarily new, that there's anti-gender and anti-trans legislation and mobilizations happening globally. Particularly, we hear a lot about what's happening in the US and the UK. All of this inevitably has a negative impact on the well-being and mental health of trans and non-binary folks in Canada. And trans health right now should really be a priority for public health and beyond for everyone, as trans folks can be vastly underserved in the healthcare system. And they can face multiple different barriers to care, structural barriers, institutional barriers, and individual barriers. So just a couple of examples of these barriers. In Canada, trans non-binary people are less likely to have access to a family care physician. They're more likely to have had negative interactions with a care provider, sometimes rooted in stigma or discrimination. They have difficulty accessing consistent access to gender affirming care, difficulty accessing HRT, and can experience delays in even accessing gender affirming surgeries. And we all know that the COVID-19 pandemic has and continues to exacerbate these issues and worsen them as well. And finally, another barrier that is important to bring up is because of these experiences, but also in the anticipation of these experiences, is that we see trans and non-binary folks actively avoiding healthcare for fear of mistreatment or stigmatization within these settings. And the last point I'll make is just, it's important to also look at trans health holistically, right? So keeping in mind various social determinants of health and how those can be broadly impacted for trans and non-binary folks. So a couple of examples is that we know that folks can be more likely to experience things like family rejection, economic precarity and insecurity, housing insecurity and homelessness, negative interactions and unfair treatment in the criminal justice system, and as I said earlier, like inadequate access to healthcare and poor treatment when they're in those settings. So given this info and everything Veronica has shared and what Travis will be sharing shortly, it's so important that we keep trans health equity at the center of our efforts and our advocacy.
You've said, and again, when I talk to you, I learn something new every time. And when you were talking about, that intersection, that's the word I think of, the intersection of inequities, and how someone who is transgender or gender expansive, their likelihood of also experiencing homelessness. There's data on it. That identity also increases risk of food insecurity and risks of poverty and not, as you said, not having access to a doctor. So when I think about the intersection of inequities and how those multiply the risks to health and change the life course of someone who is transgender, gender expansive. And when you talked about gender affirming care, I think about some of us, our brains tend to go to the medical right away. Hormones, surgery, transitional pieces, which are part of it. I also think about gender affirming care within the community. So when you go to public spaces, when you go to public health, sexual health clinics or vaccination clinics, is the care that you get, the way that you're treated, also affirming of your gender. And that's because I think public health sometimes gets lost in, well, we don't do surgery or we don't do the medical pieces, but we are part of the health system and we do provide care. And care is not just the medical care, it is also our social care. And to segue to pass the mic to Travis, one of the things I've learned from you, Travis, in the past when we've talked about conversion therapy. It's similar. When we talk about conversion therapy, we tend to think about sending kids off to a program that's away at a specific space, and it's a specific conversion program. But conversion practices happen every single day. They happen in our language. They happen in our expectations and the stigma and discrimination that people experience that are trying to convert or prevent people from being transgender, gay, queer, which is not the idea. And so conversion practices happen on the spectrum too. So that's part of what I'm thinking. Travis, what are your thoughts here on why it's important to talk about transgender health equity?
Thanks. I'm not sure I can add any major points to what Brittany and Veronica have already outlined. I'm in full agreement that really what's at stake here is a matter of suicide prevention, a matter of assertively and consistently reminding trans people that they are included and they are welcomed and they are perfect as they are. Diane, when you mention conversion practices, which have, of course, been on all of our minds a lot, particularly as our federal government has expressed more and more interest in understanding the scope and nature of these practices. I think it's really important to maybe make some finer points around what you were just saying, Diane, that like, for those of you who are, I'm 43, for those of you who are like my age or older, you might remember these films like, But I'm a Cheerleader, or more recently, some other films that have featured conversion practices in this kind of like camp, go away, we'll pray the gay away kind of setting. And the reality is conversion practices are very, very varied. They look really different depending on the setting in which trans and queer and other 2S LGBTQ people find themselves. What defines conversion practices is an ideology. It's an idea that the practitioner, the person that you're sitting in front of, somehow knows better than you yourself know who you are. They somehow have a preference, a predisposition to say, you are going to be cisgender, you are going to be heterosexual, and I will put whatever tools forward I can to try to convince you of that. That is dangerous. It is discredited by every major health professional organization I can think of. And yet, as you say, Diane, they continue to occur in lots of insidious ways. And so that is, yes, one of the reasons why I'm here today. But I also, I am an epidemiologist, and I want to really appreciate, Veronica, your sharing vulnerably your own history of struggles with suicide and making that a personal issue. And then you mentioned the statistics. And as an epidemiologist, when I teach epidemiology to public health students, to healthcare providers, we talk a lot about, let's look at the distribution of health or disease and try to understand how we can effectively prevent this. And what we know from the epidemiology around suicide and other mental health indicators among trans people, in particular from the Canadian Trans Pulse study, is that yes, we see almost 20-fold higher rates of suicide ideation and attempts among trans versus cisgender people. But that rate comes right down when we see trans people in environments where their identities are affirmed. And this includes, yes, access to appropriate healthcare, gender affirming healthcare, but also social affirmation and social transition, respect for pronouns, respect for names, actually creating environments where trans people feel like they can fully participate and be included. And we're not there yet in Canada. Quite the opposite, I think, as Brittany alluded, we're seeing an unprecedented retrenchment into LGBTQ rights. I'm very fortunate to have spent most of my 43 years seeing gradual stepwise improvement in legal and social protections for 2S LGBTQ people. And now we are at an unprecedented moment in North America, in Turtle Island, where we're seeing politicians politicize trans lives and now regress on some of those policy protections. I'm deeply concerned about what's happened in Saskatchewan and New Brunswick and what's proposed in Alberta. And I want to thank the Canadian Public Health Association for assertively speaking out against this. But what we're seeing is politicians using this as a political issue to try to encourage teachers and other adults in positions of authority to misgender trans youth. to constrain the ways in which trans youth have their identities respected and affirmed in the classroom. We will have to see what this looks like in terms of the public health impact, but by all available evidence, we can predict that this is going to only increase those rates of mental distress that we were talking about earlier. So that's why I'm here. I'm deeply concerned, and I believe, as my panelists have said, as you said earlier, Diane, and you'll hear us say over and over again, all of us in public health, all of us in society have a role to play in standing up against these political retrenchments and in repeatedly, assertively saying to trans people, I see you, I respect who you are, and I'm going to look at dismantling some of those barriers that are keeping you from achieving full health equity.
That's really beautiful. Thank you, Travis. One of our earlier conversations, you said to me, we need, another reason why it's important is that we need to prepare for the health needs of transgender people that are specific to people who are transgender and gender expansive. And if we don't address those needs now, or if we ignore those needs now, there will be an increase in those needs because that will worsen their health. And so we need to, as public health people, we need to be prepared for that. I want to go to the next question, but before I do, I realize I didn't comment on something earlier on that I should have. It's pretty obvious in looking at our panel that we are all white people. And that is one, I'm not quite sure how to phrase it. It's unfortunate because it's not representative of the people who are interested and passionate about this topic, and it's certainly not representative of the people who are part of the transgender and gender expansive community. This is not intentional. We actually did everything we could to try and avoid this exact situation. It comes down sometimes to availability, relationships, trust, comfort level. There's a multitude of really complex factors that lead someone to either join a space like this or to not join a space like this. But I just wanted to reassure the audience that this was not dismissed and this was not intentional. And we had a lot of really early formative conversations with numerous people of color who are part of this community to help form the direction. So I hope that reassures some a little bit. Building on what you were saying, Travis, in terms of the politicization and the public health roles, I really want to dive in to what we can do, what public health can do in this space. So what are some settings and examples of action for public health to promote equity for transgender people? And Brittany, I wondered if we could start with you on this one.
For sure. Thank you. So I think it's really important that public health plays a role in combating the mis and disinformation that's happening and being weaponized across Canada. So like most people know on this call, in our current socio-political climate, but also elsewhere in the world, as I mentioned, there are multiple politicians and policymakers who are weaponizing mis and disinformation about trans people, as well as gender affirming care, specifically in some areas targeting youth. And these tactics are being used on purpose to produce a variety of feelings and outcomes. So they're using these tools to induce rage and fear and hatred, and they're certainly doing so for their own political gain and their own political agenda. What's unfortunate is that the use of mis and disinformation that we're seeing in Canada and beyond is that trans folks and gender diverse folks are being further stigmatized and marginalized and harmed. And I think that's why public health should really care about what we're seeing happening all across the country. And for me as a researcher, it's really hard to see that some of these attacks on trans youth and gender affirming care are being rooted in quote unquote science, really, which is biased and bad science, such as the whole rapid onset gender dysphoria thing. And that doing so provides these politicians and policymakers with quote unquote evidence by which to oppose affirming care, to roll back access to care, and can also conveniently provide cover for their actions. And I just want to be really clear, and I think this is important for public health to know that And you mentioned this earlier, Diane, actually, that gender affirming care at its core is really the validation, the respect, the recognition of a trans or non-binary person's identities and their experiences. It does not always mean there's medical interventions. If there are interventions desired, this is always done with care and careful consideration and planning, particularly with youth. There's teams that make decisions about this. And I would love to just plug this great quote by a pediatrician, Dr. Simone Leboeuf, who's based in Edmonton, who said, please leave politicians out of exam rooms. So what we're seeing right now, the weaponization of this misinformation is leading to our healthcare being subject to the whims of current political parties. And unfortunately, really attack on trans people and youth, and it's unacceptable. And I'll leave it there.
Was having a mouse problem. Yeah, thank you. Thank you, Brittany. And I'm really glad you spoke to that mis and disinformation. And what I'm understanding is that, you know, public health really has a role to play in dispelling some of those myths and clarifying what the truth is, in addressing that mis and disinformation, and you know, in that, hopefully, you know, quelling some of that fear and prejudice and stigma and all of those things. Travis, I'd like to loop you in here in terms of you know, settings and examples of actions. I know you're doing some really amazing work in a school setting, but yeah, what are your thoughts?
Yeah, so pardon the brief academic theorizing, but I am an academic researcher. And so I really think of this, for those of you who have studied population level epidemiology, social work, anything that invokes eco-social concepts. I use eco-social theory a lot in my work. And the way I think about eco-social health when it comes to safety and health of transgender and gender expansive people is that it starts with the very interpersonal interactions that all of us, many of us will have with trans people, which is really affirming identities, having respectful interactions, really taking action in our day-to-day lives to make sure that trans people are seen, respected, and are safe. But as we start to move out from in those concentric circles of the eco-social theory, yes, a lot of different settings, in fact, every setting in which trans people find themselves becomes a critical site for addressing some of that inequitable burden of mental health and other health disparities that trans people face. So, Diane, you mentioned schools, and you know, we have some examples in Canada where I'm thinking, for example, of the SOGI 123 curriculum that was developed and expanded here in British Columbia through the leadership of the ARC Foundation, where we are seeing provinces, and in particular, school districts and teachers. It's not an even environment, right? It depends a lot on whether you're lucky enough to get a teacher or you're lucky enough to be in a school that has really invested the time and resources to understand what it means to have a trans affirming curriculum. But there's examples of that. There's examples of gender and sexuality alliances that are expanding across Canada at the leadership of trans and queer youth. There's examples of changes in school policy to make sure that everyone has access to safe, accessible washrooms. But it's not, there's no silver bullet, there's no single approach. There's pardon the plug for another book, but you know, in those of you in education spaces, there's a lot of discussion about whole school approaches. In other words, rather than think this is the job of one educator or the job of one policy to make a safe environment, we actually need to be having a multifaceted strategy. And I've been doing a lot of work with my team here with credit and shout out to Stephanie Black and Sarah Watt, who are working in a sexual health education space at looking at how do we make sexual health education comprehensive, science-based, evidence-based, but assertively inclusive of queer sexualities, of trans bodies, of trans experiences. And how do we then make sure that's evenly accessed across schools? Because we don't want it to be left to, do you happen to have a teacher who's invested this time and these resources? That's something that public health is involved with. can be more involved with. Many of you I saw in the registration are public health nurses. For those of you who are public health nurses who work in schools or have a relationship with schools, this is something that you can speak out about to administrators in particular, to identify ways in which you could bring more trans and queer content into schools. As the eco-social theory kind of moves out, we look at communities, and we know that some communities have better access to resources than others. Here in British Columbia, my team developed a website called MindMap BC that's now handed over to the expert stewardship of Community, our queer resource center here in DC. And when I look at that site and I try to find safe spaces for trans people and trans youth in particular, I notice that there are some areas in British Columbia where I worry that a trans youth will have to travel a very long way to find a safe and affirming space. That is something that we as public health can do something about. We can figure out, how do we get more funding to trans-led groups and organizations? How do we get gender inclusive and safe spaces embedded within our existing sexual health clinics, community health clinics? There's a lot of opportunity here for intersectoral and networking work. And then the last kind of the most all-encompassing and sometimes scariest concentric circle of that eco-social theory is that of government jurisdiction. So here in Canada, a lot of this falls upon provinces and territories because that's the jurisdiction responsible for healthcare and delivery of education. And unfortunately, as we said earlier, what we're seeing is different provinces taking different politicized stances. I think that in public health, we have tended to treat politics and policy engagement as the third rail. Like, we don't want to touch this. We need to be neutral. We have a government role. We can't speak up to that. And I want to actually challenge that stance, because I see a really robust history of public health practitioners and leaders engaging with politics. I'm thinking about the AIDS epidemic, when governments were chronically underfunding any kind of conscionable public health response. It was public health nurses, it was healthcare practitioners, it was public health leaders who actually spoke to politicians and said, this needs to change. I'm thinking about access to a safe drug supply. I'm inspired by my provincial health officer, Dr. Bonnie Henry, having consistently spoken out against our premier about what public health evidence tells us is needed to ensure that we are supporting the lives of people who are using a tainted drug supply. I'm thinking about vaccine hesitancy and vaccine denialism. This is, whether we like it or not, this has been politicized and it's only becoming more politicized. If we as public health are going to sit back and say, oh, we can't touch that because it's a matter of politics, we're losing that battle when it comes to fulsome distribution of vaccines and realizing the public health benefits of it. I could go on and on. Harm reduction, gun violence, reproductive health rights, immigration-related health rights, climate change. These are all politicized issues, as is trans health equity. So now is the time for all of us to find those spaces. I'm not pretending that it means you're going to go to the premier of your province and demand a change in policy. We have to work in stepwise fashion. We have to work in coalitions, but we have to work together to start to stand up against these policy retrenchments. They're dangerous. They're against what we know in terms of public health evidence, and all of us have a role to play. So I could go on, but I'm eager to hear from my panelists. So I'll step back now, Diana.
I love everything you just said, and I knew you would bring that lens. And we talked a lot about the politicization and being active in the political space. Veronica, you've been listening quietly, and you're one of the most brave political voices that I know. So what are some of your thoughts about what public health can do, some settings, examples, but if you want to comment on the politicization too,
yes,
go ahead.
I will. Reflecting on the question, what are some of the settings and examples of actions for public health to promote equity? You could stop there, because this is the piece around equity for one group needs equity for everybody. And in that respect, a lot of the work that I do that has the most impact is around education. And if you see opportunity for education to happen, get that education, whether that's for yourself or whether you bring it in for a group. You shouldn't be asking the community or the people that you're looking to education to do that education themselves unless they're open to doing it. And that I've made that choice to be that educator. I see those opportunities in some places and I make the case, and I get asked to do education. But I think one of the other pieces here is that the settings are everywhere, and this is around that piece where allyship becomes important. And the particular piece of allyship that I want to pull up here is that allyship really counts in those places where the people people or group that you are allying for are not present. That's where allyship really stands up, and that can be done everywhere. So in terms of this, allyship and education, but the politicization is a piece. The personal is political, and there's often a bit of a misunderstanding between what is political and what is party political. And these issues are and have become political. They're not party political, although they often end up along party lines and those kind of divisions, but it's not a party political piece. It's a politics piece, but it does affect everybody. So, for instance, there have been political rumblings about denying access to the trans community other than based on their gender assigned at birth, based on their birth certificate. But it's more restrict. The proposals I've seen are more restrictive than that on those that are looking to do this. And it's about restricting trans women for all sorts of reasons that are based on false assumptions, false narratives, some of the political history that we have and legislative history. The issues around bathroom access were tried in North Carolina in 2016, where restrictions were enacted at the beginning of the year, and by the end of the year they were taken down. And within 2 weeks of that restriction being put in place, a cisgendered woman was denied access to a bathroom by what I call bathroom vigilantes, a male bathroom vigilante. And most of the restrictions that then, or most of that kind of vigilante action that happened came from males. Most of that false information is the conflation of trans identities and what has become the calling cry of groomers, which has been tested in court and been thrown out. And that was in Ontario court, and you can see that spreading wider. These issues will affect everybody. If someone decides that they politically want to use the trans community as that item that they garner support around bathroom access, it's going to affect every woman in Canada. Every woman is going to be tested against what society dictates femininity or womanhood to look like. It's a way where people are trying to police what genitalia looks like fundamentally. And I do not understand why people think that they need to do that, other than some deep set biological reason to fight it or the other F word. And I'm being blunt because a lot of people don't see it until their eyes are opened. So yes, this is political. It's been made political, it's been made party political. But going back to the source of this question, education and allyship. And you need someone to come and do education. It's kind of what I do these days.
It's really powerful words. And, we've already floated into this space of the political nature. And I knew this would happen, when we were planning our conversation. It's like, we can't separate the political nature from the public health strategies. And so we're solidly here, and you've all made a very say convincing argument, but that's not really the word. I mean, you've made it very clear why this political space is a space for public health action and why it suits. When I was a frontline public health practitioner as a dietitian for a lot of years, and when we're trained in a certain profession, we're often trained to be mediators and apolitical. But when you enter into the public health space and you're doing the work around equity and population health, it is inherently political. We also have to remember, I think, my own experience is that, politics or being political isn't just government. It is relationships. It is negotiating positions. You can be political on a community level. You can be political in your work. It doesn't just mean government. It means political action and tackling those really tough issues. Before we slide to questions and answers from the audience, because we do have quite a few, does anyone want to expand a bit on, what this means about being political in our public health work? What are some public health responses to, hate, stigma, discrimination? What are some political things that public health can do in this space? I'll just open and see who might want to jump in.
Sure. Since my mic is still open. So my political action is all of those. I understand it's politicians and government. I understand it's through level of government, but I understand it's those that I interface with. I'll tell you what I do, because I'm not a public health worker, but I can talk about what I do. So, for instance, last year we had a bunch of protests with the Million Marchers, and I organised the counter-protest here in Sydney, but I called it a celebration of diversity. I took that opportunity to go and have one-on-one conversations with the protesters and ultimately with the protest organiser. And each of those conversations ended with, "Oh, I didn't see it that way." And that's often what the action, one-on-one action, results in. Those conversations where we can understand each other, where I can understand where they're coming from and they can understand where I'm coming from and why it's an issue. In the more governmental space, I engage my MLA, I engage my MP, and in the last year, I've engaged MLAs across multiple departments, across multiple provinces on these issues, and I've engaged every MP. So in light of some of the comments that I saw coming from a certain quarter, from a certain MP, I wrote to all of the MPs around as to why the issue was so difficult and why it needed to be addressed and why it couldn't be.
I think we're having some internet problems. Veronica, she's in rural Cape Breton. Travis or Brittany, did you want to to comment or further build on that?
Yeah, I'll just really quickly mention three things that I think any of us could do after today's webinar, and I hope most of you will. The first is there is a new campaign just in the last couple of weeks called We Are Allies. And this is a very extensively planned, extensively researched campaign with credit to folks at Transcare BC and UBC. But it's a campaign for everyone across Canada to address myth and disinformation about trans people. And so you can share this campaign, you can boost this campaign, you can make this campaign a matter of public health interest. I think at the last webinar you hosted on this topic, Diane, you had Faye Johnston and Momentum Canada, and I think I can safely speak for Faye here. They need your help. They need other people, not just trans people, to actually step into the space of advocacy and speaking out about trans issues. So I really encourage you to check out their Action Center. And finally, just to go back to what I was saying at the beginning of the webinar, when I think about my role as a settler and my role in reconciliation, particularly with Two-Spirit communities, I think about land back and what does land back look like for Two-Spirit people. And what it means to me is getting behind Indigenous Two-Spirit-led organizations that are thriving, that are doing the very difficult work of dismantling colonial systems of the gender binary. And so I just want to mention here the work of Two Spirits in Motion, and also from your last NCCDH webinar, Diane, I think Jesse Dame was here, Two Spirit program at CBRC. Both of these organizations are doing incredible work to move this forward. Reach out to them and let them know you appreciate their work, you want to support it. How can public health do more to give land back, meaning funding, credit, teaching, expanding the word of the Two-Spirit movement? So I think, yeah, we are allies, momentum, and the Two-Spirit movement are three very concrete actions that we can all do to be more active allies, to be accomplices in what needs to happen here.
Yeah, I love that. I love that concept of being an active ally, and that's political activism. That's political activity, right, in that space. And we've all got the ability to do that. And, you know, with CPHA, Canadian Public Health Association, putting out that statement, that is also another opportunity to be political. So for those of us who work in organizations where, you know, we're restricted for whatever reason, we can be members of our national organization that does support these issues as well. And that's another opportunity. Brittany, did you want to add anything before we head to question and answer?
Sure, just quickly, if you're on the East Coast, like a couple of the panelists are, the Wabanaki Two-Spirit Alliance is a great organization as well that I would love to plug alongside the amazing organizations named so far. And I think a lot of what I had prepped to say for this question has been amazingly said already, but just to reiterate, right, like public health has roots in social justice and human rights and equity, and it has for a long time. So by that nature, public health has to be political, right? And what we see right now is that we're asking public health to be adaptive and evolve its response to current public health issues. And right now, trans health and healthcare is one of those primary public health issues. So if public health is looking for, you know, actions and things to do, I think really thinking about the recognition of the health disparities and challenges that trans folks across Canada can face, and how, like, what impact our socio-political climate is having on the rollback, the policies, the legislation rollbacks, and how all of this is contributing to the harm of trans non-binary people across Canada. So like a role could be in fighting the mis and disinformation, but also in just humanizing trans people as a public health response. So in last year, EGAL partnered with Spark Advocacy to do a poll, and only 1 in 3 Canadians knew someone who was trans, and only 6% had a close relationship with someone who was trans. And what I take from this is that it means it can be fairly easy, I think, for those mis and disinformation seeds to take root, and for folks to dehumanize trans people and not understand or get swept up in the narrative around gender affirming care. And I think public health has a huge role to play here in combating these seeds from taking root. And I think lots of great solutions have been presented, but the ones that I have are really big, probably more structural or policy level. But what we're seeing in a lot of places is like limited or rollback in access to care, when in fact we all need better access to healthcare in Canada. We're seeing a lot of folks, trans, non-binary, and otherwise, just not having great access, particularly those in rural areas outside of those urban centers. We need better access and easier access and pathways into gender affirming care. There are lots of provinces and areas where there's only one gender clinic, where there might be one doctor who is taking on trans patients. And this causes a huge backlog, and folks are waiting a really long time to access care, which we've already said is life affirming and life saving. And I've seen a couple of comments come in and questions come in around education. We really need to vamp up and ramp up our healthcare provider education across the board, anyone working in healthcare and social services, really, and public health professionals, so that they can better meet the needs of 2S LGBTQI folks in their care, especially trans, non-binary, and gender expansive folks. And I'd be remiss if I didn't say we need more community-based research on trans healthcare in Canada. So I think we can make a huge impact by doing more research and then moving that research into advocacy and action.
Yes, all of that.
Just a little bit.
Just a little bit, but I love that you took it to the structural level and structural level things. And you know, sometimes when I'm working with public and community health organizations across different topic areas, you know, and knowing this from being in public health frontline myself, you know, we sometimes think, but the system hasn't, we got to wait for the system to get there. But we've got to wait for the structures to get, but we are the system. We are in the system. We are part of the structures. So even though I might not make federal policy or law, I am still part of the system. We're still part of the system. So I love it that you took it broad, because we all have a piece to play in that. So thank you. We have a lot of questions. I have no idea how I'm going to make sense. And I'm glad I've got my folks in the background who are grouping them for me, but we have a lot, and I'm not sure we're going to get to all of them. But I do want to, I know where I want to start, because someone has offered some really, really thoughtful and vulnerable information about themselves and asked a really, really important question. And so I want to honor that vulnerability by going to that question first. The question is, do we have strategies to reach out to individuals who may find comfort and peace, but haven't come out yet due to a variety of factors? This person talks about familial influences, cultural challenges, perhaps if there are people who are new to Canada or who have recently arrived, you know, how do we help folks who are in this scary space, you know, to learn, accept, not acknowledge things about themselves? How do we address the intersectionality piece? And, you know, what role can public health play in that? Does that make sense? I was trying to sort of lump it together. And I really want to just thank the individual who told me a bit about themselves and asked that question. Thank you. Travis or Brittany, can you talk at all to the strategies about reaching individuals and helping them get to a place of acceptance?
I mean, I think for public health in particular, because that's how you kind of angled the question there. I think for anyone who's front facing or client or patient facing, it's really about creating those environments that are safe and accepting and affirming, where someone who's visiting a healthcare provider or a social service provider could potentially ask questions, gather resources, pamphlets, handouts, web resources, and kind of being potentially a first point of safe contact. I think that anyone working in those more public facing settings could play a role in kind of creating that environment for folks who are questioning or wondering about what resources exist. And then I thought, like, when I heard that question, I immediately sort of thought about less so of a public health perspective and more on a personal individual perspective of just trying to create and find community and finding out what resources exist in your area. So potentially looking into, you know, community-based organizations and services in your area. And if you don't live in an area that has a physical community center, finding out what exists within your province or territory for resources and contacts. There's really great folks working in community-based organizations who are running great programs, creating great resources, who are really aware of, you know, even the provincial and territorial needs within their regions, who are doing great work. And I think that they would be, I imagine that any person working in that organization would be open to a conversation, a coffee chat, a call, an email, a text. But yeah, for public health, it's like really creating that safe space where someone could potentially share something about themselves, ask questions, get resources, free from judgment, free from stigma.
And because you never know when it's going to happen. Charles, I see you're going to jump in. You don't know when it's going to happen. I've been that person for people, and it's a real honor. You have to be ready. You have to be ready to respond in a way that's helpful and supportive. Travis, did you want to jump in?
Yeah, I just want to add one suggestion, and I also want to appreciate the person who asked this question for being so vulnerable, for sharing their personal experiences. And I'm sorry to hear that they have had to go through this struggle. I think also in the question there was an element of what if you're part of a newcomer community? What if this is happening in across intersections of immigration or cultural differences? And a few months ago, I was at a Vancouver City Hall meeting where they unanimously passed a renewal of the transgender safety plan. And a few of the city councilors who are themselves Chinese Canadian said, I'm really concerned about the ways in which we continue to replicate these services and programs and education in English. We're actually not effectively reaching across communities. And so I think one thing that we can do in public health, like when I was working in the health authority, I would look at the services we offered, I would say downstream in my public health hat, like when people go to the hospital in translation. And we have incredible translation services here in the province of BC. If you come into a healthcare facility and you need to be served in your language, we can do that downstream at the point of a healthcare encounter. What this person is asking about is upstream prevention. How are we actually making sure that trans youth, as they're coming out, as they're finding their identities, and the immediate families and communities around them are prepared to support them in that journey? And I think I can say confidently, we have not effectively reached across linguistic and cultural intersections for this. So one very simple thing that public health could do, that we in fact do for lots of other public health programming, is reach out to the folks at We Are Allies, reach out to some of those organizations that Brittany is talking about and ask, how can we take some of these excellent, there's great accessible information in English on We Are Allies for parents and loved ones of trans people to learn and dismantle some of that dis and misinformation. Let's get that translated into all of the languages. That is a very simple, practical step that any of us can do. This is not about one health authority or one province trying to respond to an isolated incident of transphobia. This is systemic. It's coming across the board in Canada and North America. So we have to work together. So let's find ways that we can take these really good resources that exist in English and French, get them into Chinese, Punjabi, Hindi, all of the other languages that we need, so that we can do some of the meaningful intersectional work that needs to happen.
Yeah, I agree. And Veronica, thank you for your addition in the chat box about public health, promoting peer support, connecting resources. Public health is really good at playing that connector role and at playing that bridging role. There has to be some intentionality for public health to play that role when it comes to the health of transgender and gender expansive people. But that can be a role. And, Travis, what you said about translating materials. I used to work in a public health region that was very white in English. And so we had mostly everything in English. But as newcomers started to come to the area, we were reaching out to other health units for infant feeding information, for example, or for information on things. So find, if you've got someone and you don't have the resource in the right language, find the resource or get it translated, or bring someone from within your staff that maybe works in a totally different, unrelated department that can come with you and help you communicate with that family to provide a bridge before you've got the right resource, right? There are collective resources within a public health organization that can be pulled on, I think. So there's a few questions around, when medical practitioners are going to be held accountable and responsible to provide the care that's needed. And if they can't, to make the right referrals. Those who claim ignorance as a refusal to provide care. So, under that umbrella of, well, I don't know, and so I can't do it. How do we address this piece within medical professions? I was a dietitian for a long time. So, dietitians, nurses, doctors, like maybe even some social workers, Travis, right? So broadly, those healthcare professionals, how can we address the gap in knowledge, but how can we address the accountability piece? It's a hard one. I think about the role of regulatory colleges and regulatory bodies. Canadian Pediatric Society has made some really relevant statements. They wrote a letter in response to some of the proposed changes in Alberta. So getting some of those national health professional bodies behind you, working with those health professional bodies and the regulatory colleges to have, in this case, gender affirming care woven into the expectations, both for education and for continuing quality improvement, continuing education. Those are things that come immediately to my mind. Veronica is saying, and she's correct, there is no excuse for ignorance. Every province has training material available. Public health knows this, they can read it. Public health can promote it to their professionals within the area as well. And truthfully, if there are regulated health professionals that are providing unsafe care or inadequate care, there are formal structures to address that with the colleges as well. But Travis, you look like you're thinking.
Yeah, I was just gonna say, and again, I'm sorry to overwhelm folks with resources, but I'm assuming that people are here because they want to learn and take more steps. So here, a shout out to my colleague Florence Ashley, who's a professor at University of Alberta. They're a legal scholar and are, I would say, have done the most work at looking at what conversion practices look like for trans people, particularly in a medical healthcare context. And Florence and I wrote a piece for Canadian Medical Association Journal in right after the federal government passed its conversion therapy ban, in which we asked, why are medical regulators in Canada not taking action against physicians who continue to practice a form of wait and see, delay access, unsubstantiated delays in access to gender affirming care. This is something that I think we've kind of wanted to pretend like it's not happening. But what we heard over and over again in the testimony that was provided to Parliament during the hearings about the conversion therapy ban is that, in fact, it is still happening. And so I agree with you completely, Diane. There's a role here. My upstream mind wants to say, like, let's really invest in education, but you're right. We also downstream need to be taking regulatory action against healthcare practitioners who continue to hold on to a bigoted attitude that is actually preventing trans people from accessing the care they need and deserve.
Yeah, and that's a really good point. You make me think about Fran Baum, BAUM, a number of years ago, wrote about the nutcracker of health equity. And when Fran wrote about that, she wrote about there needs to be, and I'm a visual, so I'll do a little demo here, but there needs to be, pressure, policies, formal leadership action, formal government action, but there also needs to be community level work and advocacy, and together they crack the nut. So it's like a nutcracker. So they crack the nut of health equity. And so what you were talking about was making me think about that there are actions at a number of levels. We have to have the upstream, the education, the more education and the better medical education, but we also have to have downstream regulatory level work to help crack the nut. And so I think it's all aspects. We tend to drift downstream because we want a quicker solution. So it has to be both, but you make a really good point that there's an upper level too. There's a number of questions asking for resources to support, professionals who work in labor and delivery. Lots of folks, Travis, want to know about the sexual health education curriculum. Will it be available? It will be, I assume, at some point. And so you can maybe share it with us so we can share.
Oh, I can quickly answer that. We're not developing a curriculum. We're understanding what determines who receives trans inclusive, queer inclusive sex ed. So we're doing, we will this fall be launching a survey of teachers because we know that teachers are doing incredible work, going above and beyond, and sometimes even contravening policy to make sure that trans students in their classroom are supported. But that shouldn't be left up to individual teachers. I would, however, if you're looking for curriculum, I would suggest reaching out to CCAN. That's the Sex Information and Education Council of Canada. They're doing great work, and they're one of our community partners in the project.
Thank you. Thank you. And the other questions here that are asking us for case studies, resources on having really tough conversations. So what I'm going to do is go through some of these because we're not going to get to them. I'll go through, find out what people are asking for, and I'll compile some resources and send it out in that follow-up email so that people can sort of look for that. And I want to acknowledge that, Veronica put a really important comment in our panel chat here. I don't think it's made it to the chat box yet, that public health folks can organize as a cross-country unit. Public health collectively can write letters and calls for action. So again, the Canadian Public Health Association statement is one example of that. In Ontario, I used to be a dietitian in Ontario. The Ontario Dietitians in Public Health do collective advocacy work around weight, stigma, bias, and discrimination. There's intersectionality in that related to sexuality and race, for example. And so within your professional bodies, within your regions, you can independently organize and work collectively to do that work, to do that important advocacy work. I think we do need to transition now a bit to sort of closing down, but like I said, I will go through the questions that we haven't answered directly, pull together some resources to address a lot of what people are asking for. One thing that I do want to share, and this is in the interest, I can see if I can do the screen share. In the interest of identifying other actionable tasks, strategies that people can work on, we've set up a Slido poll. So we're not going to broadcast the results live, but what I'll do is compile them and organize them a bit and send them out and follow up. But we're asking the audience here, what are some examples of action that you have taken to promote health equity for transgender people and gender-expansive people? So maybe I'm going to leave this up, ask folks to complete this Slido poll. But as we do that, I want to just go back to our panel here. And, we've heard a lot today from our audience. We've heard a lot from each other. I think I want to know, how are you feeling and what are your reflections sort of as we close out on this conversation? Where can we go next? Yeah. I'll let you think for a second. Go ahead, Brittany.
I don't know about the audience, but I saw so many links posted in the chat that I certainly have some homework to do. Some of the things that were shared are new to me even. So I'll be taking those back as further reading for myself. But it's been really lovely having this conversation and just seeing how much people are interested and invested in the conversation and making changes and making improvements. And for me, that feels very affirming and like we're headed in the right direction. So I encourage folks who attended to find out, connect with the organizations in your city or area, check out the resources that have been shared and all the national organizations doing really great work, and learn more, take some actions, and connect anytime with the folks on this call. But it's been a pleasure.
Yeah, thank you. It's the pleasure is absolutely all mine and all of ours. Travis?
Yeah, I echo Brittany. This is I've learned so much from the three of you, Veronica, Brittany, Diane, and also from some of the resources that are being shared here. So definitely, if you see opportunity for collaboration, if you have ideas for how we can better work together, please do reach out. I'm happy to be contacted as well. I wanted to mention two more resources or suggestions. There was a question about improvements in data, trans-inclusive data that we didn't get to. And so I'm just going to put a link with a plug to Dr. AJ Lowick's Gender in Sex and Methods and Measurement Toolkit, which basically provides a very accessible template for how all of us can do a better job in measuring gender diversity. I think there's no perfect approach, but definitely those of us who are working with public health data, we have a lot of work to do. And then I really think, Brittany, I'm thinking about the statistic you shared about how like only 1 in 3 Canadians know someone who's trans and only 6% have close connections. I think that is troubling to me, not surprising, given the number of trans people there are. But I think there's other ways in which all of us can increase our empathy, our understanding of trans experiences. So one last book plugged from me. So this is Zena Sherman's latest book called The Remedy, Queer and Trans Voices in Health in Canada. And, it's a very quick read, but really beautifully compiled set of stories from trans and queer people and their kind of challenges with the healthcare system. And I think that, sometimes reading, watching films can give you just a little bit more understanding of experiences that are different from your own if you are among those 67% who unfortunately have yet to meet a trans person in their lives. And thank you so much, the NCCDH, for shining a light on this really important public health topic.
It's really lovely of you to say. And, it's that statistic is very interesting to me, that that 67% of people don't know someone who's transgender. I would say they don't know they know someone who's transgender. There are a lot of folks who are transgender that we don't know are, and we don't need to know are, because they're people. And so I would just challenge all of our thinking. Those of us who, and at a time when I thought I didn't know people who were, boy, did I ever, and you have to just be willing to see past what the binary is that's sort of solidified in our minds. And Veronica, I'm appreciating your comment too, that, not all the issues are in healthcare. Public health helps, and it makes me think back to, Brittany, what we were talking about earlier about gender affirming spaces and gender affirming care on a larger scale. Public health can help with understanding things like name changes, paperwork issues. We can change the pronouns and the questions that we ask on forms, for example. Now, that doesn't mean our work is a micro task. It doesn't mean the work is done. It's part of creating an affirming space, right? We can work with other organizations, and we can, acknowledge what we don't know. So, Veronica, I appreciate that comment, and your comment that the space is sacred, that the community is sacred. That makes any conversations that we have around this issue also sacred. And so I think that's something that I continue to learn, and that I've sure learned a lot from all of you about. One piece as we close out, we've all had our reflections. I'd like to offer these for our audience here as points to also reflect. Where is your organization in terms of understanding and supporting gender and sexual diversity for transgender people, for anyone who's part of the 2S LGBTQI+ community? How do you apply or support the implementation of those inclusive and affirming language in your work? How do you create gender affirming spaces and provide gender affirming care? How do you approach your life with gender affirming care? What are some of the related challenges and opportunities for this? And I think, I'm a mom, I'm a wife, I'm a sister, I'm a friend. When I think of all of those roles that I play in my own life, not just in my NCCDH role, I think about the importance of me as a human being, reflecting on, where am I at in terms of understanding and supporting these issues? Where have I made mistakes? How do I react when I'm called out on those mistakes? How do I get better? There's an expression that goes something like, today I'm going to work on being the best version of myself. And so this piece is a journey, right? It's a journey. And I'm not perfect. And so I appreciate that the growth opportunities that I've had in doing this work. And it's very clear that there's more to do in this space as well. So this has been a very, very, very important conversation. And I think, I'm thinking too of I have a few little things written here. As I talked to probably about a dozen people over the past number of months, leading up to today, there were a few little things that stuck out for me. One thing was that I was talking to Alicia Fredkin in BC, and Alicia's I don't know if any of my panelists know Alicia, but she's a huge advocate and a brilliant person. And she teaches me something all the time. She said, we can't make change when we're yelling at each other. Can't make change when we're yelling. We have to talk to each other. We can't yell at each other. So we have to sort of take, put down our resistance and be willing to talk to each other. And I also talked to a young scholar named Christian Hui, and he's at Toronto Metropolitan University. And, Christian said to me, he said, in the same way that there's no pan-indigeneity, we talk about, we can't talk about all Indigenous people with the same brush. There's no pan-indigeneity. There's also no pan-queerness. We can't, there's such uniqueness wrapped up in the conversation or in the experiences that people in the 2S LGBTQI plus community have, that we also can't assume that because we've learned something in one space, that now we know it for every space and for every person. So those are the pieces that I remind myself of often, and that I will carry with me. This is a bit about how you contact us at NCCDH. My brilliant colleagues who've been pulling the text strings in the background have put the evaluation link in the chat box. Also, when the webinar closes, the evaluation should pop up automatically on the screen. But with that, I just want to express how sincerely grateful that the National Collaborating Center is, not just me, Diane, but our whole center is, with the knowledge and commitment to this work from every single one of our panelists, to everyone who came to the webinar today. I said this last year and I'll say it again, this is not the last you're going to hear from us on this. We are committed, I am committed, we will keep doing this work, and we would love to hear from you at any time. When you receive the slides, you'll also see my email on one of those. I'm wide open for any feedback and any ideas, or you can contact NCCDH generally. And with that, I will say merci and adieu, and we will meet again. Thank you, everybody.